Hello, and welcome to the ASCO Daily News Podcast. I am Dr. Neeraj Agarwal, the Director of Genitourinary Oncology Program and the Professor of Medicine at the University of Utah Huntsman Cancer Institute and Editor-in-Chief of the ASCO Daily News. I'm delighted to welcome two internationally recognized leaders in the field, Dr. Toni Choueiri and Dr. Monty for a discussion about two practice-changing studies in kidney cancer published this year, KEYNOTE-564 and SWOG 1500. As a quick introduction, Dr. Choueiri is the director of Lank Center of Genitourinary Oncology at the Dana-Farber Cancer Institute. He's also the Jerome and Nancy Kohlberg Chair and Professor of Medicine at the Harvard Medical School. Dr. Monty is a professor in oncology and co-director of City of Hope's Kidney Cancer Program, and he is an associate editor of Cancer.net of ASCO. Our full disclosures are available in the show notes, and disclosures relating to all episodes of podcast can be found on our transcripts at asco.org/podcast. Toni and Monty, what a day it has been for our patients with kidney cancer. I woke up with the news of the FDA approval of the first ever adjuvant immunotherapy for patients with renal cell carcinoma. It is so great to have you both on the podcast today.
Glad to be here. Thanks, Neeraj.
Thank you, Neeraj. So glad to be here.
So let me start by asking questions to you, Toni, first. So you recently published the primary results of the phase 3 KEYNOTE-564 study showing the efficacy of adjuvant therapy with pembrolizumab, an immune checkpoint inhibitor in patients with renal cell carcinoma. And this study led to approval of pembrolizumab this morning. So please tell us more about this study design and why did you do this study?
Thank you, Neeraj. And thank you really, ASCO, for this wonderful podcast series. And a big hit. I always listen to them when I'm driving or jogging. And really, thanks for this opportunity because kidney cancer adjuvant therapy has been something like a holy grail we're trying to find for a long, long time. The first adjuvant trial, a randomized trial in renal cell cancer was in 1973. With radiation therapy. And since that time, all the trials except for one has been a complete failure in a way. And the first adjuvant immunotherapy trial was with old immunotherapy cytokine that we don't use much anymore. And was in 1992. I was not done with medical school. I was not actually done with high school at that time, let alone medical school. And now that we have, as we all know, a revolution in the oncology field through these immune checkpoint inhibitors that reinvented immunotherapy in cancer. And now that pembrolizumab has shown activity in patients with more advanced disease, we thought about taking this into the adjuvant setting, a setting of patients where they were subjected to surgery, but on the pathology report, we knew that the risk of this cancer coming back, of recurrence, is somewhat intermediate high or high. These are patients that have stage 2, but grade 4, stage 3, T3, T4. These are patients that had node positive resected. And we took even patients where the kidney is out, but also they had a removal of a metastatic site, let's say a lung metastasis, within a year of removing the kidney. And we know these patients, we refer to as M1 and ED, are at quite high risk of recurrence. And we randomized 994 patients to receive pembrolizumab for a year versus placebo. And after a median follow-up of only 2 years, so I want to insist here that this is short for any trial in general, we saw a decrease in the risk of recurrence or death. The hazard ratio for disease-free survival was 0.68, so a 32% decrease in the risk of recurrence or death. We looked at safety, and we already are familiar in the field of GU oncology with pembrolizumab, and we didn't see, when we looked at the safety profile, any surprises, any enhanced toxicity. Of course, immune-related adverse event are the number one concern with pembrolizumab. There was no death on trial related to pembrolizumab. We saw around 7% of patients needing high-dose steroid to medicate these immune-related adverse events, and some patients had to come off therapy for that. We also took a look, Neeraj, an early look at overall survival. Only we had 25% of events, 51 deaths. And we did not meet the very rigorous statistical significance that is needed to say that study is positive for overall survival. But the hazard ratio was 0.54, a 46% decrease in the risk of death, which kind of encouraging. And after a year, the curve start to separate. Before a year, they're not separating. And that is consistent with prior studies in general.
This is a very interesting point you just raised, that DFS, disease-free survival, is strongly positive, and even overall survival is trending in right direction, right?
Correct.
That's great. So obviously, I would like to raise another point here. When we talk about adjuvant study, we usually think about a localized kidney cancer, which is removed by the surgeon, and then patient is coming to see us for treatment in adjuvant setting. But this study, I would like to highlight, as you said, also included patients who had oligometastatic disease, had successful surgical removal of the oligometastatic disease, and they were also eligible for this trial.
Yes, absolutely. And I think this is somewhat on the recent side in clinical trials in kidney cancer. The reason for that is that in practice, we see those patients, and we even had two small trials in the TKI era with sorafenib and pazopanib. Small studies were also completely negative. So we thought here that we should not exclude these patients. They end up being 6-7% of all participants, but this remains an area of unmet medical need.
So how is the hazard ratio in those patients who had metastatic disease removed and then treated with pembrolizumab?
Yeah, it was very low. It was 0.2, so 0.29. And this was great to see. I don't want to go into really over-interpreting these results. All the hazard ratio, when you look at subgroup analysis and the forest plot, all the hazard ratio are less than 1. We didn't see something, let's say, 1.5 in favor of pembrolizumab. Now, you go into a smaller subgroup, then your confidence intervals are very large and hard to interpret, except that to say, look, on average, there could be a significant benefit here, but we can't tell.
Sure. Absolutely. I agree with you. So how this is going to affect the current treatment paradigm, which is for patients with newly diagnosed metastatic RCC, where combination of VEGF TKI plus IOs or IO-IO combinations have become standard of care treatment paradigm.
I do believe it will be a standard of care currently in the right population. There are a lot of unanswered questions, but that will be answered hopefully with more follow-up. We have already, beside these results, reported. So these results were reported in the plenary session at the 2021 ASCO. But later on, another analysis dealing with patient-reported outcome and quality of life was reported at ESMO and also showed no detriment in quality of life. That's the voice of the patient. No detriment with pembrolizumab. There are a lot still to do and a lot of unanswered questions, such as the non-clear cell histology, those patients who had surgery of their metastatic disease more than a year. But most important, I think two questions. One, how can you know from the get-go who are the patients that need adjuvant pembrolizumab? We do not have any valid ctDNA, and I know Dr. Paul involved with a lot of these type of research. We don't have any ctDNA test that is really that faithful and sensitive in the MRD space in renal cell. Many of us are working, so we don't know. We may end up over-treating patient that need surgery only, and actually we may end up under-treating patient that need perhaps pembro and another drug. Sure. And the second thing, in those patients, and I hope it does not happen, but unfortunately it will to some extent, whose tumor progress on adjuvant pembrolizumab, what do you do? What's the treatment paradigm? And actually there is no data. This is a data-free zone. And I would think somebody whose tumor progress, tumor continue to grow or grows while they're actively on pembrolizumab, on IO, is way different than someone whose tumor come back after 2-3 years from stopping the drug. Should we treat them with the same drug? Should we treat them with a TKI plus IO? Luckily, there are trials that are ongoing in patients whose tumor progress after PD-1, PD-L1 inhibitor to give them a TKI as a control arm or a TKI plus an immune checkpoint inhibitor. And I know Dr. Pal is very heavily involved with such trials. So hopefully we will answer this question, but not anytime soon.
Very interesting. And definitely new results are posing new challenges on how we practice medicine here in the coming future. So Monty, you are leading a trial with a very similar trial with atezolizumab. And I'm really hoping, we are all really hoping that we see the other trial being positive. So we have more treatment options for our patients.
I couldn't agree with you more. I mean, I definitely think that Toni's study really adds a lot of fuel to the fire, suggesting that this strategy of adjuvant immunotherapy may be successful in localized renal cell.
And I'm not going to really delve into the side effects of pembrolizumab and atezolizumab because these drugs are used quite often. They are in widespread use for different types of cancer. But just a quick question. Any safety signal, Toni? Did you see any safety signal with pembrolizumab in this patient population?
Yeah, this is an excellent question. So nothing that would be different than using pembrolizumab overall, knowing in other diseases as a single agent. So this drug, not first in a human, as you know, and it's been approved in combination or as a single agent in many diseases. A tumor that the three of us treat is bladder cancer, and we know from another study how to use pembrolizumab. I think that the use of corticosteroid is somewhat of an objective way, at least to me, in looking at immune-related adverse event. And, it has been between 5 to 10%, so we're not way off here. But there is no doubt that there are patients that we had no death on trial attributed to drug that may have, with pembrolizumab, some serious toxicities. We had patients that had autoimmune diabetes, hypophysitis, pneumonitis, quite uncommon, but not impossible.
We'll still need to keep an eye for them, basically.
No doubt.
Yes. So changing gears, let's talk to you, Monty. You recently presented the primary results of the SWOG 1500 trial in patients with metastatic non-clear cell renal cell carcinoma. Could you please tell us why you did this study and how this study's design was unique compared to similar studies in this setting?
Yeah, no, absolutely. Toni did a great job of outlining areas that were sort of free of data, in the adjuvant space, particularly with immunotherapy. I think that the data-free area for us in kidney cancer for a long time has been non-clear cell histologies. We just don't really know how to treat them. I actually got advice from Toni when I was devising SWOG 1500. We planned it out as a very simple study comparing sunitinib and cabozantinib. And, Toni will remember this history well. It sort of went through several iterations. The study blossomed into a 6-arm trial. Ultimately, it turned into a 4-arm study looking at sunitinib versus cabozantinib versus 2 other MET inhibitors, savolitinib and crizotinib. And ultimately, the study was boiled down to essentially what we'd originally proposed. 2 of the MET inhibitors, savolitinib and crizotinib, failed to surpass an initial analysis for PFS. So ultimately, we demonstrated a superiority with cabozantinib over sunitinib for progression-free survival.
So what is the current treatment paradigm for patients who have newly diagnosed metastatic papillary RCC now?
I think for patients who don't have genomic selection, I think that cabozantinib remains a standard. I really want to champion, and maybe Toni can talk a little bit more about this, a study that Toni is leading called the SUMITA trial, which I think has a really innovative design. And it's going to be genomically characterizing patients and randomizing to savolitinib with durvalumab or sunitinib. Tell me, Toni, if I have the design right there.
Yes, actually, this is a study. It's a study in a specific population. It's not in papillary RCC as much as in those 30-40% of papillary RCC that have MET-driven tumors. So MET alteration, whether through chromosome 7 duplication, through chromosome 7 trisomy, through mutation or amplification, these patients will get either control arm or they will get savolitinib, which is a pure MET inhibitor that is devoid of VEGF-related toxicities, savolitinib plus durvalumab, or durvalumab alone. So 2 experimental arm and 1 control. And the reason for this is we saw activity and quite, a good toxicity profile with savolitinib, a pure MET inhibitor, over sunitinib in an earlier trial that was sunitinib against savolitinib in selected patient population. The study had to close early, so despite the numerical difference, this was not statistically significant. And then in another study led by Dr. Powles and colleagues, there was also some interesting activity, how durvalumab could augment that activity. So we're launching a phase 3 trial with 3-arm that you described very well.
That's wonderful. So what are the next steps, Monty? I mean, this is amazing to see you designing a investigator-initiated trial. This was your concept. You designed it. You built this to be a huge multi-center trial, which was open across the country, funded by National Cancer Institute. And congratulations for making that happen. It's rare for us to see these trials going from a concept stage to a national trial and then changing the standard of care. So what are the next steps now for you and your team in SWOG for papillary RCC or metastatic papillary RCC? How do you build up further with the backbone of cabozantinib?
I really appreciate the question, Neeraj. It's so critical to understand that we're just not quite done yet. Toni's study, as I've mentioned, is incredibly innovative. I'm also really thrilled to be working with someone who you've mentored so well, Ben Mon, at the Huntsman Cancer Institute in Utah. And he's actually designed a brilliant study, which we're going to be leading together, which looks at cabozantinib with or without atezolizumab. Recently in a study that you and I and Toni were a part of that we just published in JCO, we actually saw quite impressive response rates with the combination of cabozantinib and atezolizumab in patients with papillary RCC, around 47%. Those response rates were actually replicated in a separate study run by Joe Lee at Memorial Sloan Kettering. In the context of papillary disease, response rates were again above a threshold of around 40%. So I think there's something to it. But until we really subject this to randomization, I think we're not going to know whether or not cabo plus IO is the standard. So I encourage everyone to consider Toni's study. I encourage everyone to look out for our trial of cabo plus or minus atezo, which should be rolling out next year.
What is the name of the trial or the number for our audience?
Yeah, we lucked out with another great number. We got 1,500 for the first trial. This is going to be SWOG 2200. So SWOG 2200, I think, is due to open maybe in the first quarter of 2021. 2022, excuse me. That's
fantastic news. Any new signal? We know cabozantinib is already approved for our patients with metastatic RCC, courtesy Meteor trial led by Dr. Choueiri here, Toni. It's amazing to see how many times you have changed standard of care for our patients with metastatic RCC. So any new safety signal of cabozantinib in this patient population with metastatic papillary RCC?
Nothing that I appreciated. The toxicity profile was pretty much on par with what you'd anticipate for cabozantinib in the setting. Major side effects were hypertension, hand-foot syndrome, diarrhea. Nothing that really sort of stood out relative to what we would expect in a clear cell population of patients.
That's great. Any final messages for our patients, for our audience? for our listeners?
Well, let me start. Maybe Monty can add. It's been, and it hopefully will continue to be, this humbling experience where median survival from metastatic RCC in mid-2000, not long time ago during our training, has been 1 year, and now in metastatic disease, it's 4 to 5 years. And that is only going to get better. And then it's even more humbling that to be in a time where you can talk about adjuvant treatment in this disease, renal cell cancer, that continues every year to kill, unfortunately, 14,000 Americans. That's just in the US alone. So we have to continue in getting more targets, more drug, more reasonable combination in the right patient, whether through specific biomarker that are tissue or blood-based, or specific liquid biopsies that can tell you who has and who doesn't have cancer at the microscopic levels.
Thank you. How about you, Monty? Any final message for our audience?
I couldn't have summarized it better than Toni. Just such a wonderful statement around optimism for what we've achieved so far and what's yet to come. And if I could emphasize to anyone in the audience today, the need to keep progressing the field further with clinical trials, I think that would be my underlying message.
Thank you again, Toni, Monty, for your valuable insights and thoughts. Thank you for all the inspiration. This is indeed so inspiring to see your work and which is changing the lives of our patients on a daily basis. Our listeners will find links to your studies in the transcript of this episode. I wish you all the best.
Thank you.
And thank you to our listeners for your time today. If you enjoyed this episode, please take a moment to rate, review, and subscribe wherever you get your podcast. Thank you so much.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.